So, welcome back, everybody, from break. Um, I'm Molly Rideout. I am a pediatric hospitalist and a member of the ICONS team with the VCHIP PQC. And I have the honor to introduce our next speakers. Doctors Gold and Sarathi were first authors on a paper that was recently published in Pediatrics. It was called Neonatal Toxicology Testing Ethical Considerations for Pediatricians. And this is how we discovered them. It was just published a few months ago. So we were thrilled. We reached directly out to them and we're thrilled that they agreed to present at our conference today. So I will introduce them. Dr. Christine Gold is a pediatric hospitalist physician whose expertise pertains to the care of newborns with prenatal substance exposure. She's a member of the Colorado Hospital Substance Exposed Newborn Quality Improvement Collaborative Steering Committee and a co-chair of the Support Colorado Policy Analysis Work Group. Her work focuses on improving care and reducing inequities for patients with substance exposure and their families, both at the hospital level and at the state and national levels. She has frequently spoken to clinicians, child welfare teams, and legal teams about newborn toxicology testing and best practices for care of birthing people and infants with prenatal substance exposure. And Dr. Leela Sarathi is a pediatric hospitalist also, medical director of the Mass General Hospital Newborn Nursery, and an assistant professor of pediatrics at Harvard Medical School. Her academic interests include quality improvement, health equity, and safely reducing unnecessary interventions in newborn care. She has collaborated on many original research investigations, hospital policies, and quality improvement initiatives aimed at promoting equitable, family-centered care for dyads affected by substance use disorder. Outside of Mass General Hospital, she's a member of the steering committee nationally of the American Academy of Pediatrics section on hospital medicine newborn hospitalist subcommittee, and also nationally the Academic Pediatric Association's Better Outcomes Research for Newborns, or the Born Network, which is a well-known national network. So it's wonderful to have you both here. The title of your talk, as you can see, is going to be Balancing Care and Consequences, Ethical Decision-Making for Neonatal Toxicology Testing. Thank you for being here.
Great. Thank you for the introductions and for having us. And it's really great to see all of the work that you're doing in Vermont. I love meeting people from other states and, collaborating on all of this important information. So today we're going to talk about neonatal toxicology testing and ways that ethical perspectives can improve best practices. And Dr. Sarathi and I are both pediatricians, but I think a lot of the information we discussed today can really be extrapolated to the care of birthing people as well. If it's okay with everyone, I'd love to hold questions until the end so we can get through all the content. And then I'm happy to answer questions at that time. Next slide. We do not have any disclosures. Next slide. So we have learning objectives for this talk, but I do want to start with setting a foundation for our discussion. And I suspect this is likely a review for attendees present today, but toxicology testing is frequently utilized in newborn nurseries and neonatal ICU settings to identify substance exposure. And there are some benefits, but I think more recently we're starting to scrutinize those benefits and say, what is the actual benefit when we do this test? And we're beginning to understand that benefits of the testing are likely much less than previously considered. And I believe in a prior conference, the Vermont PQC has discussed toxicology testing in depth, including limitations, screening versus confirmatory testing, et cetera. So for the sake of time, I'm only going to briefly touch on those topics today. Next slide. So it is true. And can you go back one slide, please? Okay, perfect. Next slide. Thank you. So it's true that there are potential benefits to testing. Some of the benefits that may exist for testing neonates for substances include really when there's an unclear presentation of a newborn, and maybe you can't get further history from the birthing person, or that history from the birthing person is inconsistent with what you're finding, and after further discussion, there's a broad workup that will be done, and perhaps this is one of many tests that will be done. But it's a medical test that should be done to determine medical care of the newborn. And so essentially, the conclusion of all the information from testing is that it may represent exposure to a substance at some point, but it may not. And all of the ways we learned as clinicians and early in our career that toxicology testing is the gold standard for identifying substance use is probably not true. So benefits and limitations are being recognized. And when we order tests as clinicians, including neonatal toxicology testing, we have to think about what are we hoping to learn and what is the test I'm ordering able to tell me? Because tests within manufacturers and between manufacturers can vary greatly. A hospital lab director could change the test they're using from day to day without telling anyone. So it's important that you know that what you're looking for is able to be found by the test you're ordering. But there's a lot that these tests can't tell us. So it can't tell us things like when a substance exposure or use occurred, how much of that substance was used, the degree of impairment from that exposure, the presence of an actual substance use disorder. It doesn't tell you, did the person administer the substance to themselves? Was it someone else? And it really doesn't tell us, is this newborn safe to go home, even though we've used it that way in the past. So beyond not answering these questions, there are other limitations of testing. And this is probably where it gets into a review, but there are screening tests, there are confirmatory tests. The screening tests are most commonly used, but they are cheap and they respond, or the results are available quickly, but they're fraught with cross-reactants and false positives and false negatives. And they reflect the medications we've given in labor. So labor is a painful process. We often give medications like fentanyl, even through an epidural. And from Dr. Sarathi's institution, there was actually someone who looked at this and showed that fentanyl tests in newborns when their parent had an epidural can stay positive for that fentanyl for at least 30 hours after delivery. So we really have to consider the context of the results we obtain when we order these tests. Next slide. So we know that toxicology testing isn't perfect, and ultimately we all do this differently from even the institutions within my health system to across the country. And unfortunately, for pediatricians, there's really a lack of statements or clinical guidelines from major medical organizations stating how to use neonatal toxicology testing in a best practice way. And so this has led to the huge variations in care that we see, and then it's led to inequitable outcomes in the way the testing is performed. But although this aims to identify prenatal substance exposure and promote these outcomes, the unintentional negative clinical and social consequences are beginning to be published on. Next slide. So that brings us to why we're here today. Healthcare facilities and clinicians are becoming more aware of the variation in practices, the consequences and inequities in this testing, and it's prompting reevaluation of hospital practices and then creation of or revision of policies influencing this toxicology testing. So we are seeing more states provide educational discussions like today and improving information about being aware of and responding to toxicology testing limitations. Next slide. So our learning objectives for today are listed here. So we wanted to set that foundation so we all start on the same page. And today we're otherwise going to expand into what are the harms of the testing that we're doing? How do ethical principles help us understand how we can do this testing in a better informed way? And then we'll describe different approaches to testing and articulate what we think is best practice from an ethical perspective in policy development. Next slide. Okay, so harms of testing. Next slide. So separate from all of these technical medical limitations that I've just reviewed, importantly, harms and consequences of testing do exist, even though most of the time they're not intended to be harms and consequences by the ordering provider. So False results, both false positives and false negatives, can lead to not only inappropriate management in the hospital or the clinical care setting, but it can lead to inappropriate ways that we prepare to discharge, inaccurate information communicated to outpatient providers, and potentially inappropriate involvement of child welfare. So these false results, especially in screening tests, can have significant consequences. Child abuse and neglect reports based on test results when there are no protective or safety concerns. That is becoming, I think, more popular to discuss, and importantly so, because although state laws sometimes vary in the presence of a test result to make a report, these tests aren't great. And so why are they involved in these reports? Do the harms of testing outweigh the benefits? Oftentimes they might. And again, we just want to emphasize that we really want to think about this as a medical test. If I order this medical test, how is it going to impact my medical care? Not, am I ordering this test because someone in a different non-medical setting is requesting it? So really important to consider. Next slide. Other possible harms from testing, so disruption of patient-clinician trust. Now, I know this is a balance, but if someone says, yes, I use these substances, and you say, great, I'm going to test anyway, I don't know what the chances are that you find much different from what the person has said. Or if they say they haven't used anything and there's no concerns on the physical exam of the newborn, and you say, great, I'm going to test anyway, that really can disrupt that trusting relationship and possibly impact the way that person seeks care for themselves or their newborn later. Again, we talked about inappropriate treatment plans, parent distress, and psychological trauma from fear of or actual involvement of child welfare is very real. And ultimately, the confirmatory tests that we do to see if a screening test was accurate or not take a long time to come back. So then the clinician is faced with, do I keep this newborn and dyad in the hospital until the test result comes back that confirms this information? And that can be upwards of a week. And that has costs and challenges to a family as well. Next slide. Possible inequitable outcomes that I've alluded to include, again, this disengagement from medical care, prenatally, postnatally, for the newborn after birth, because of the worry of child welfare involvement. And this will ultimately worsen health disparities and worsen clinical outcomes for the dyad. We know that in response to toxicology tests of newborns, we do over-report certain patient populations compared to others, and this ultimately perpetuates bias, stigma, and racism. So there are medical limitations to the test, there are harms of the testing, not just medically, but also psychologically and downstream consequences that can last for a long time. Next slide. So usually at this point in a talk I give, people say, oh my gosh, okay, so it's all terrible. Like what do I do then? How do I use this test in a way that it's useful? And so ethical principles, I think, are a really helpful way to center ourselves as we shift our way of thinking to improve the way we do neonatal toxicology testing. Next slide. So in our paper, for anyone who's read it, or if you haven't, we do allude to a lot of ethical principles, but today I really wanted to focus on these four basic concepts within the idea of principlism. And I'm not a medical ethicist, but I think these are basic principles that we learn early in our medical careers. So when it comes to thinking about toxicology testing and how these principles can be helpful, first, we can think about respect for autonomy, and we have to consider the birthing person and the newborn in the dyad as a whole. We can't extrapolate one versus the other. It's so intricately linked. And so autonomy really means recognition of and respect for a patient's right to make informed medical decisions regarding treatment based on their beliefs, opinions, and perspectives, free from other people's perspectives and personal limitations that prevent meaningful choice. So when it comes to neonatal toxicology testing, one of the ways I think about autonomy is obtaining informed consent from the birthing person for their newborn's toxicology testing and balancing the obligation to protect and promote the health of the newborn with parental rights, which also starts to get into this other concept of respect for persons. When it comes to beneficence, so this is an obligation to promote the well-being of the patient, and in this case, the dyad. So for example, obtaining a neonatal toxicology test to better understand a newborn's clinical presentation or assess for potential exposures with the goal of promoting improved clinical care and outcomes for the newborn. When it comes to non-maleficence, so this is really a duty to avoid or minimize harm to the patient. And in addition to benefits, considering the harms of neonatal toxicology testing, including false results, response to test results, and other downstream consequences, including child abuse and neglect reports, really falls into this category. And then justice really stands for equitable treatment of all patients, as well as equitable distribution of healthcare resources. So an example in neonatal toxicology testing is trying to avoid exacerbation of or introduction of disparities in who we test and how we respond to these tests with the downstream consequences. And this also involves considering historical disparities in substance use, types of substances used and associated stigma, and then providing access to or resources to treat substance use disorder and give supports. So again, when you think back to these concepts, this framework can actually ensure that neonatal toxicology testing is performed ethically and equitably, promoting the well-being of the birthing parent newborn dyad, which is beneficence, while importantly minimizing harm or non-maleficence and respecting parental authority. Next slide. There's a lot of other concepts we could discuss, but for the sake of time, I won't spend much time here. But there is a table that's very small on the screen that's in our paper that reviews all of these concepts and specifically looks at how they play into neonatal toxicology testing decisions. So we're happy to review more later or share that with you after the fact. Next slide. All right, and so I'm going to shift to Dr. Sarathi, who's going to review the next couple of learning objectives.
Thanks. So now that we've kind of established a framework and reviewed some of the potential harms of testing, to Christine's question, when do we test? So we wanted to first review some of the more common frameworks that people use when approaching toxicology testing. Next slide, please. So first, just to kind of review screening versus testing, as Dr. Gold mentioned, the American College of Obstetrics and Gynecology does recommend universal screening for substance use at the first prenatal visit. And part of this is to avoid missing potential exposures, and also universal screening to reduce discrimination and potential biases based on race, ethnicity, or class and stigma. This statement was affirmed by the American Academy of Pediatrics. And I think it's important to note, too, that both ACOG and the American Society of Addiction Medicine recommend against routine biochemical testing for illicit substances. And that's partly based on prior work that does demonstrate inequities. So this word routine testing is, I think, where we want to focus the next couple of slides. So if you could go to the next slide, please. But just to review screening, there are a couple validated screening tools in the birthing person population that are endorsed for use to quickly assess for any potential substance use that needs to be explored in more detail. Next slide, please. So when talking about toxicology testing, really what we're trying to figure out is how do we select these newborns who might be at risk for substance exposure or withdrawal? And there are a couple of approaches that have been endorsed over the years. We'll talk about universal testing first, and then criteria risk-based testing, which is probably the most commonly employed by different hospitals right now. And then finally, we'll talk about a clinical indication-based approach. Next slide, please. So universal testing, at first blush, might sound like the ultimate solution and one that aligns the most with justice, because here we are universally testing everyone to make sure that we're uncovering any potentially undisclosed substance exposure. And by testing everybody, we're not introducing bias. Sorry, I think we need to advance the slide a little bit. But the problem with universal testing is it doesn't account for the room for bias and inequity to be introduced in downstream consequences. So how we interpret those test results, there's often room for bias just in that moment when you say, oh, well, I know you, and I'm sure this was a false positive. We're not going to do anything about it right now. There's a lot of inequity in reporting. So these are actually two studies that looked at universal testing from very different periods in time, but with pretty consistent results. In 1990, Chasnoff and colleagues found that although rates of detection of substances were about the same in Black and white pregnant patients, Black women were 10 times more likely to be reported to Child Protective Services. And then Roberts and colleagues found similarly that there were similar rates of substance use, but Black women actually sought treatment more frequently and were still 4 times more likely to be reported to Child Protective Services. And then unfortunately, there are still downstream consequences from there and room for inequity in what Child Protective Services does with that initial report filed by the provider. The decision to even take the case and investigate, and then subsequent decisions such as home removal. And there is some evidence demonstrating inequities down the line. Next slide, please. It also doesn't fix the limitations of the test result that Dr. Gold reviewed, that there are many false negatives in these tests. So this study from 2015, which was done in Ohio, and they performed universal toxicology testing on maternal urine samples, they found that most positive tests were in dyads that already had risk factors such as active or recent history of substance use. And then there were a handful of babies who actually went on to have such severe withdrawal symptoms that they required pharmacotherapy, but that test was negative. So it just underscores how the test is really one component of a much larger assessment that we need to be doing for these patients. And it might be falsely reassuring if you rely solely on universal toxicology testing. And then the test doesn't account for the clinical context of this substance exposure. So this study from 2022, they actually did cross umbilical cord sampling for a year in Utah, and they found that 10% of their samples were positive for something, but they acknowledged that they had no way of knowing whether that was due to intrapartum fentanyl administration or prescribed substances versus non-prescribed substances. So again, the test is one biochemical result that really can't provide us with a lot of useful information about the context of substance exposure or substance use disorder in the dyad. Next slide, please. So criteria and risk-based testing is very commonly used, and it's an approach where you basically try to standardize care and reduce biases by applying clinical scenarios that are thought to confer a risk or suspicion for substance exposure. So historically, these have ranged from clinical features such as placental abruption in the birthing parent or a neonatal stroke in the baby, to social risks such as anything from sex work to inadequate prenatal care. And by applying these criteria, the thought is that we'll be able to capture substance exposure in a group that's thought to be more high risk. Next slide, please. But these approaches have also been found to be pretty low yield. So this is a study that Molly Siegel at my institution did, and we looked at over 60,000 samples and found that about 2,000 dyads were tested, and a little under 200 test results were positive, but the vast majority of those were for cannabis only. So of the 80 remaining samples that had a positive test that was not predicted based on history, this is kind of a breakdown of based on clinical indication how high yield that test was. So in patients who had a history of recent substance use disorder, about 10% of those tests were positive. For patients with inadequate prenatal care, about 6% had unexpected positives. But for some of these other indications, like monitoring for someone with controlled substances based on an infant's clinical presentation, none of those test results yielded any useful clinical information. Next slide, please. And then there's another really significant concern with risk-based testing is that there's a huge overlap with other social determinants of health. So for example, by targeting patients who have limited or late prenatal care, a lot of those patients are also experiencing poverty or underinsurance and other barriers to care, and we're potentially exacerbating existing health disparities by then further subjecting them to toxicology testing and all of the potential harms. Next slide, please. So this is a hot off the presses quality improvement publication that just came out in Hospital Pediatrics last month that actually demonstrated this in real time. This hospital attempted to use a risk-based approach to reduce bias in their testing. They actually used criteria: known maternal drug use, no prenatal care, late prenatal care, medication for opioid use disorder, and then this kind of other clinical concern category that was newborn neuroirritability or signs of withdrawal. And then there was kind of a little bucket for other. And they actually found that the opposite of what they were trying to achieve happened. They increased testing quite significantly in their Black African American population. And it stayed about the same for their white patients. So this is just an example about how risk-based testing can actually exacerbate health disparity. Next slide, please. So clinical indications is another approach. And in 2020, the AAP clinical report on neonatal opioid withdrawal syndrome did recommend that we perform neonatal toxicology testing when it will inform clinical management. So this could be interpreted as when you have symptoms of intoxication or withdrawal in a parent or newborn that can't be explained by a history that you already have. So if we know that a patient is on medication for opioid use disorder and then the baby is showing signs of opioid withdrawal, the test probably isn't going to give us a lot of more useful information. But if you don't have that history, as Dr. Gold was describing, then a test might be indicated. I like to kind of think of this phrase that we use a lot, at least in pediatric hospital medicine: when it will inform clinical management, replace that with when it will benefit the patient. So really getting back to this idea of beneficence. And I mean, a lot of test results are going to change our management and not often for the better. But to think about, if I get this test result, will it help me to safely care for this baby and optimize that baby's clinical outcomes? There's one other scenario in which toxicology testing is sometimes considered, and that's if it's requested by a parent who is trying to demonstrate sustained remission or something similar. I personally think that is reasonable, but really requires a thoughtful conversation with the parent about the potential benefits and harms of testing in that scenario. Next slide, please. And then finally, back to this idea: can neonatal toxicology testing predict safety? So some people feel like it's useful to test because it can help determine whether breastfeeding is safe. It certainly could tell us if there is a metabolite of a potentially harmful substance in the birthing parent at that time. But it's really only a snapshot, and it doesn't tell us anything about past use or future use. And so while it could be useful for breastfeeding, I would argue that anticipatory guidance about the potential harms of exposure to substances through breast milk is probably just as, if not more effective, because it also helps to prevent against future exposure. And then this question of, can neonatal toxicology help us to predict safety in the home? I mean, the idea of using a medical test to make a social assessment, I think, is something that we've mentioned is a little difficult to argue. But also taking a history and considering the broader social context is really important here, rather than relying on a medical test. Next slide, please. So this is a graphic that we developed for our paper, and it really tries to capture the fact that this birth hospitalization is part of a care continuum, and we are trying to optimize outcomes during the birth hospitalization, but it's crucial to partner with outpatient providers and engage them and try to corral resources to support this dyad throughout the care continuum. And in this way, we will be better able to identify and support potential safety risks for the mother and the child. Next slide, please. Finally, just want to make sure that we talk about informed consent. So this aligns with the ethical principles of non-maleficence, autonomy, and confidentiality, which has to be balanced with the concept of paternalism and the idea of preserving the autonomy of the newborn who might not be able to advocate for themselves. According to ACOG and the ASAM, there are some key components of informed consent. It's important that the provider is really explicit with the patient about what the goal of testing is here. That if we are testing because we're concerned about a clinical feature, then that our goal of testing is to help clarify that to provide care. If we're testing because of some other reason, then I think it's important to share that with the patient. Informed consent should also include a discussion of who's going to have access to these results and what the potential ramifications of a positive test might be. And informed consent should always include the patient's right to refuse testing, although there are some limitations on that. These societies also affirm that written consent is preferred for accountability as an educational tool and according to patient preference. Next slide, please. Finally, when you're ordering a test, I think even before the test is ordered and ideally before it results, it's important to think about how we're going to respond to test results. So we spoke a little bit about the importance of confirmatory or definitive testing because a lot of these tests are immunoassays that can have a lot of false positives. And so it's important to know what we're actually looking at. And then to have a plan for disclosing results to the patient, to have a follow-up discussion to share what was found, to elicit any additional history that might help explain the findings, and to provide resources to the patient because we often focus on reporting as the pediatric provider when a test result is positive. But it's equally important to think about how can we actually support these patients with substance use disorder if we do find that that's an ongoing issue for them. In terms of reporting also, I think we'll talk about this a little bit more, but what gets reported has to be carefully considered. There's a lot of literature that demonstrates that the year postpartum is an incredibly vulnerable time for the birthing person, and also that there are many potentially harmful consequences of reporting on the birthing parent. And so it's important to think about how are you going to respond to these test results in terms of filing a report before they're ordered. Next slide, please. This is just one more slide that I probably should have fit in earlier, just demonstrating that the inequities in children that actually undergo an investigation by Child Protective Services following a report. So as you can see, the largest proportion is in Black infants who are subject to a child welfare investigation following a medical professional report. So just really important to think about all of these downstream consequences when we're thinking about how we respond to test results. Next slide, please. All right, so now we've talked about sort of what is our individual report approach. And the question is, how can we turn this into practice? Next slide, please. So it's important to develop an institutional policy to try and standardize this as much as possible to eliminate both implicit and explicit bias. So when we're thinking about developing hospital policy, it's important to include all stakeholders and when possible, patients and families' perspectives too, to make sure that hospital policy does stipulate the need for universal screening during the prenatal period, and then to have specific criteria for neonatal toxicology testing to try and eliminate the bias in individual provider decision making. Inclusion of informed consent, what that entails, but ideally actual documentation is an important part of hospital policy. And then recommendations for when referrals to Child Protective Services or other interventions should be made. That requires the person developing the policy to be familiar with local and federal requirements for reporting, and also to have some knowledge of what resources are available to support the dyad who might be experiencing substance exposure. And then finally, considering how to optimize health equity should be an inherent component of hospital policy. So policies should be trauma-informed and person first, and they should promote supportive over punitive consequences. And there should be an ongoing assessment of outcomes to ensure that we aren't unintentionally creating disparities, like in the Michigan example, and a plan for how to address those if they are inadvertently incurred. Next slide, please. I'm just going to talk for a minute about legislative policy because I think this is sort of not necessarily pressing in Vermont, fortunately, or many of the states that are really, I think, actively looking at this. But just to recognize that the need for toxicology testing, as Dr. Gold, is somewhat state dependent. There are a handful of states that still require this in the instance of birthing person drug use and sometimes for reporting. And then there's this legal language that I think has provided a lot of consternation and over the years in terms of what needs to be reported. So the Comprehensive Addiction and Recovery Act of 2016 was an amendment to the Child Abuse Prevention and Treatment Act in 1974. And what this did was two things. It acknowledged that dyads need to be identified and followed to ensure that appropriate supports are in place. The second part is tricky because the CARA amendment says that reporting to the state is necessary, really more to continue to monitor rates and to ensure there are appropriate resources. But absent a mechanism for reporting, a lot of individual states have fallen on their reporting mechanisms for child abuse and neglect. And this has been the case in Massachusetts. According to my research, Vermont has a dual reporting system, as does Colorado. In Massachusetts, we're actually still working on this. It is not up and running yet. But I think this is really where the next level of advocacy can take place, that even if our individual states are well on their way, there are still many states for which this mechanism isn't in place. And it's an important way that we can start to reduce the harms that are incurred by reports when there's a simple case of substance use disorder in remission and we don't have any protective concerns. I will mention that it is important that to consider situations in which it still would be appropriate to file for a concern for abuse or neglect, but not to routinely file for substance exposure, I think is the important point here. Next slide, please. All right, you want to take us home, Christine?
Yeah, I'll wrap us up here. Okay, so some concluding thoughts. Next slide. So despite all the literature we've reviewed and concepts we've reviewed, there are still questions that we have yet to answer. So many hospitals are moving away from routine tox testing and reporting for all of the reasons we've discussed previously. But as with any intervention we do, we still need to track what's happening as a result of these changes. So by testing fewer newborns, maybe doing fewer reports to child welfare, we may minimize the harms we've discussed, but are there unintended negative consequences occurring as a result of that? And that's something that I think we need to consider in the future. In terms of evidence-based tools, so we have evidence-based screening tools for the birthing parent, but for newborns, we have testing or nothing, it feels. And it would be great to have more evidence or more tools to help figure out how to best screen newborns for substance use. Guidance from major medical organizations to standard best practices. Again, I think ACOG does a really great job of this, and we'd love to see more pediatric-focused organizations come out with clinical guidelines or best practice statements so that we can reduce variations and inequities and outcomes from this testing. And lastly, partnerships between medical systems and legal and social systems. So in my state, one of my current focuses is that I have made a lot of changes in the medical system, which is great. And then the few times we do need to make a child welfare report, we make the call, and the county's worker and the judge and the county all say, great, I want the tox test. And you're like, I've done all this work just for these teams to come around and say, I want the tox test. So there's a big gap in terms of how we partner with these social and legal teams. And I think that needs to be a focus. We can't just change the medical system. It's a good place to start, but we need to partner actively with other components that touch the care of our dyads. Next slide. So our conclusions overall, toxicology testing in neonates is frequently used, but it has limitations and harms, as we pointed out. A clinically based approach is preferred to avoid some of these unintended harms and consequences, and is supported based on the ethical principles we've reviewed. No toxicology testing in a newborn or in a birthing person can replace the patient's voice, our clinical judgment, the need for care coordination and support in response to what we find. And that's really important to emphasize. And everyone here, everyone in the clinical teams, ongoing advocacy at all levels is needed. And you are all a very important part of promoting that work. And so we need to continue to push forward to help our patients. Next slide. This is just one last graphic from our paper, but it sort of, I think, condenses everything we wrote in the paper and everything we talked about today when someone is faced with a decision about will they or will they not request toxicology testing for a newborn. Next slide. All right, so we did that as quickly as we could so we could leave room for questions or comments, and I already see things popping up in the chat. But here's the information for myself and Dr. Sarathi, and we are both very happy to take questions now or via email, and I am admittedly slow to respond to emails, but I will always get to them eventually, so in case you email me. But we're both very passionate about this work and very happy to help. And then the remaining slides we have are resources that we used for the presentation and for the paper in case anyone wants to review those. So I'll stop there, and if the team agrees, we can do some questions.
Yep, questions would be great. We have about a little under 10 minutes. So if people have thoughts or ideas, that was wonderful to hear all of your perspective and so clearly laid out. We have definitely had similar culture change takes a long time. We have also changed our breastfeeding guidelines, and there's definitely some snafus in terms of getting pressure to test birthing parents before feeding the newborn, and I think it takes a lot of education, lots of time, and like we've been talking about culture change. So what do people have questions about? There's a couple things in the chat that I think you've seen. Eat, sleep, console model, starting very early, the whole approach of empowerment, empowering families. And yes, Vermont is a leader in the cap to care requirement, separating those. It's great. Nice to hear that Colorado does that also.
Yes, well, I will point out in Colorado, so there's been a very large effort to create a notification portal, and I wouldn't say it's fully up and running. They're piloting it. To Dr. Sarathi's point, they do have built in as you go through it that what the reporting requirements are, so that if someone gets through the notification and is unsure if it was a notification or a report, hopefully that helps them decipher. But I can't wait for that to be fully up and running. So we're not quite as far as Vermont.
I think the comments in the chat also just about these really kind of gnarly clinical scenarios where there is uncertainty is really the crux of this. It's I mean, we try not to be nihilist about anything, and there's not never a role for neonatal toxicology testing. So in these tricky scenarios where you are worried about a contaminant and there are and that worry would hopefully be because the baby was demonstrating signs of intoxication or withdrawal and they needed to be managed, not because of hypotheticals. That's, I think, where engaging parents is maybe something like that isn't, it feels challenging, but is a really crucial part of this to say, this is what I'm seeing and this is what I'm worried about. And this is why I would like to test, because it will help us, first of all, sometimes, exclude something else that might be more invasive. Like, I don't want to do an LP because I don't think your baby is actually septic, but something is not right. And a toxicology test might help me to avoid other things, but it might also help me to better support your baby through withdrawal. And sometimes you might be pleasantly surprised that that actually is a conversation that goes well, and sort of in partnering with parents and acknowledging that everyone wants what's best for the child can really help to promote that trust, rather than kind of the opposite approach, which is, we don't believe you. We feel like there's something else going on and we're going to send this test. Just to call out the conversation that's happening in the chat about unintentional ingestions of parents.
And I'll piggyback on that and say that our experience at UVM, in particular in the NICU with ill infants, where we have that clinical scenario where we're wondering, is this an opioid exposure or is this something different that we need to manage differently? Those conversations I was worried about them when we rolled out our new guidelines. And they've really just gone smoothly. It's an opportunity to open up your decision-making thought process and share it with the family and really have an open, transparent discussion. So I haven't heard anybody having a really negative experience in those situations. And I think that's important for everybody to know.
I'm so glad to hear that. And I also wonder if disentangling reporting and other consequences of testing has really helped to view the test as something we do for medical reasons, for medical benefit.
I was
think about.
Oh,
go ahead.
I was
go
going
ahead,
to answer
Christine.
the next question in the chat. So is there a recommendation for starting the conversation around neonatal toxicology testing during prenatal visits if possible? I would say absolutely yes. And it is hard. I think this is me being like, woe is me, but being a pediatric provider in the hospital, if you're the first person to bring this up, you have maybe 48 to 72 hours to establish a relationship and bring all this up. It's very hard. And so I think I can't speak to everyone's experience, but in our medical system, when someone is connected to prenatal care, our providers do bring up the topic and they offer a pediatric consult with myself or a few colleagues, and we'll do a separate consult via telephone to talk about what the hospitalization could look like for the newborn, when would toxicology testing be discussed, what are their rights to agree or refuse that testing, et cetera. And it's gone a really long way in empowering patients and I think reducing the fear of the unknowns in the hospital. So I think it's not maybe widespread practice, but it would definitely be recommended.
Yeah, we do the same thing during our standard prenatal consultation for patients with a history of substance use disorder. We discuss when toxicology testing might be indicated.
And there was another direct message to me, but then the next comment actually sort of addresses it. But there is a question about, can you talk about neonatal abstinence scoring and treatment for high scores? And to the next point, so I think a lot of people have shifted from things like Finnegan scoring and how that escalates treatment for a newborn to this eat, sleep, console model. And I think that's been really helpful in terms of shifting from this objective but really subjective assessment of a newborn and sort of ambiguous decision to treat to empowering the parent to be a part of the team that helps care for the newborn and work together to decide when treatment is needed. So I'm happy to talk a little more offline about neonatal abstinence scoring and why we've shifted to eat, sleep, console, but I agree that eat, sleep, console I think has been a better approach for this. To the next comment in the chat about the challenges of someone not seeking or not maybe being able to achieve full prenatal care when there is concurrent perinatal substance exposure. I echo that challenge. And sometimes the moment we're able to really engage them is the birth hospitalization. And so I think having providers trained in trauma-informed care practices and trying to at least set the foundation of a supportive, not punitive environment will hopefully help them and get the resources they need to help hopefully achieve care for themselves and for their newborn postpartum. It doesn't help the prenatal challenges, but I think that can help reduce the barriers to seeking further care down the line. But Dr. Sarathi, I don't know if you would comment anything further.
Yeah, I mean, ideally we start early to the points that were mentioned, but there's still a lot of opportunity, and I think it can still be done well in the inpatient setting. And in some ways, I mean, it's a shorter duration of stay than the length of a pregnancy, but you have a lot of hours. And I think sometimes sort of shorter, frequent conversations can be beneficial in that context. The only other thing I'll add is just for prenatal consultations, for some of our patients who have more obstacles in making it to their appointments, we offer virtual consultations. And sometimes I've even just talk to someone on their cell phone for a half an hour just to establish any sort of connection with the inpatient pediatric team so that not everything is brand new when they come to deliver.
Can you talk about that a little bit? What is your system for the prenatal connection with the pediatric team, inpatient team?
So it's a little bit like Christine was describing. Myself and two other providers basically do the prenatal consults. We have a clinic, a wraparound clinic for families with substance use disorder that cares for them through pregnancy through age 2. And so that provider, if they're planning to establish care there, will do the consultation. But otherwise, myself or one of our special care nursery colleagues will do it. And they kind of they reach out to our coordinator and set up you can bill for virtual and phone visits these days. So we just try to set up something so we're able to have that conversation. Sometimes it's a really long one, sometimes it's a really short one. And it's not always the same provider that's, on service when they come to deliver, but just trying to familiarize them with our approach. I've, at least anecdotally, I think for a lot of patients, it does promote trust and relieve some anxiety about delivering, especially if they've had a prior experience that was less positive.
Yeah,
That sounds like a
we're
great
probably at time.
resource.
Oh, I'm sorry. Keep interrupting you. I was just want to say we have a very similar informal process. We have a few obstetricians who message us directly in Epic when they want a consult. And sometimes there are barriers to reaching the patient via phone, but I'll talk to them at 8 p.m. if they want, just because that's the one time they're done with all of the things they had to get done during the day. And yeah, it is a billable service. So for those people who have been like, how are you going to find the time and do that for free? You can bill for it. And I think that is helpful in reducing some of the barriers to implementing a prenatal consult service.
Great. Well, I want to thank you both. This has been really fantastic to talk about it with great questions. So your emails are there for anyone who has further questions and wants to reach out. And we are going to transfer to the next talk now, which is Julie Litsky.
That's